Good afternoon, everyone, and welcome to today's webinar. I'm Tom Glinski, Chief Inspector with the Board of Pharmacy. Today's webinar is our annual compliance update with an extended question and answer session. With me today, I have inspectors Barbara Wood. She's our inspector that has parts of South St. Louis and then Southeast Missouri down to the Boot Hill. And then I also have Dan Vandersand. He's our inspector for more of the St. Louis area and then has some area up in northern Missouri. Later on during the webinar, our executive director, Kim Grinston, I believe will be joining us. If you haven't been on one of our webinars before, on your toolbar, you have an option if you have trouble with computer audio, you can dial in to get the audio if you're having trouble. Everyone is muted in listen only mode. This program's been approved for 1 hour of board approved CE. You must be logged in under your own username to go to webinar in order to get the credit. I have more instructions at the end of the webinar about how to obtain CE. A reminder, the board does not submit CE to the CPE monitor, so it's important that you save your certificates. Handouts are available in 2 spots. However, I'm not sure they made it onto the board's website, but you can check there first. If you up at the upcoming events, there should be a link to it, but a few minutes ago it was not posted yet, so they may not be there yet. The other option is on your GoToWebinar toolbar. If you go down to the tab that says handouts, you'll see a PDF saying entitled handouts. We do record our webinars and we post them on our web page. And if you have a question for our question and answer session today, you can send it on your toolbar, type in the question and hit send, and we will try to answer those questions midway through the webinar today. So we'll get started now. The webinar is broken into basically 4 sections where we got some inspection issues I'm going to talk about. I will not be talking about sterile compounding inspection issues because we did a webinar back in September with our inspector Katie Bold, and that's now that the recording of that is on our website, or you can find it from this link on YouTube. So we will not be talking sterile compounding today. I'll talk a little bit about investigation trends, what we're seeing, and then I'll answer some of the questions on some slides of some frequent questions we've been getting, and then we'll open it up to our question and answer session. We did ask people to send their questions in advance. We're going to take some of those first, and then we'll take some of the ones that come in during the webinar if we have time. We will not answer every question that's sent in, so just be aware of that. So we'll move on to inspection issues. I'm just going to talk about some of the common findings that we were finding inspectors find on inspections. First topic in drug inventory, outdated drugs in the active inventory. It's a common observation, but again, you should have a standard program where your inventory is being checked on a regular basis and pulling those outdates. Expired return to stock vials, that's another common finding. Again, the reminder is a return to stock vial is good from 12 months from the date it was dispensed, so that the date of dispensing that's on that label, it's 12 months from there. Unlabeled drug containers, we do find that for various reasons, but not just unlabeled, there's just stuff missing on it, like a lot expiration date, but it is concerning to find just totally unlabeled containers, no label at all, just drugs in a vial. And then repackaged drugs, again, it could be repackaged for different reasons. They could be in vials, bubble cards, and it also includes drugs that are in automation. So if you have a robot, the cell that holds that, that's a repackaged drug. The expiration for that is the lesser of 12 months or the manufacturer's expiration date. So that's another common finding on inspection is repackaged drugs exceeding that 12-month date. And in the automation, that's if you watch an inspector, they can go to a robot and pull up that screen, and usually there's a screen on there that will tell us what's in each cell and what the expiration date is on there. And it's very easy to detect those, but it would be also very easy for the pharmacist in charge to go check every now and then. Usually it has to do with people that aren't properly trained who are loading it and entering that information into the computer or the robot. So here's some photos from some recent inspections here. An inspector, this is extreme, pulled, it was over 80 different types of products that were outdated in that pharmacy. And then here's some examples of just drugs with no labels on them. We have no idea what those are on the left, and the ones on the right had a label but nothing written on it. I will tell you, rubber banding an unlabeled vial to a stock vial is not considered proper labeling. That doesn't get you out of actually labeling the vial that the product's in. So again, anything that's out of the original manufacturer bottle should have the lot, and it would be the 12-month expiration date of when it came out of that vial, unless the manufacturer's expiration was less. Unsanitary conditions is the next thing I'll talk about. We see findings of dusty, dirty shelves, and sometimes it's the products on those shelves that are also very dusty and dirty. Dirty floors where trash, debris, loose tablets are on the floors is another thing. The sink is always a concern in a place where sanitation issues can arise. Reconstitution device, as always, the tip of that, I got some pictures of that, is always a concern in finding where there's leftover antibiotic residue on that tip. General clutter in the pharmacy, just there's no workspace, there's so much clutter on the counter, 5 days of wholesaler orders, totes are sitting there and put away, just clutter all around. The mail, I've seen pharmacies that have just piles of unread mail on the dispensing counter with little room to actually, to work. And a recent finding I noticed recently throughout this last year was leaky roofs. Multiple times inspectors have noted an active roof leak at the pharmacy on even a day they're there, or we're told it looks like your roof leaking, and we're told yes, it does leak, and management has not been able to get that fixed. So you need to make sure you're taking care of any maintenance to the building, such as a roof leak. And a lot of times that may be out of the control of the pharmacy, but somebody's in charge of the building maintenance that needs to be notified. Here's examples of dust and dirty product. You see not only the shelves are very dusty, the product that's starting to build up dust. More examples. And here, there's pretty extreme here. The other thing you notice in this is just the general organization of the shelves. Bottles are knocked over, and the background on the one on the right is bottles that I don't even know if they belong in that section, upside down, sideways and stuff. So general unsanitary conditions of dust, dirt, dust bunnies there. Here's an example of a floor that hasn't been cleaned for quite a while. Here's an example of just stock product on the floor. We now have a rule that went into effect on August 30th that says drugs should not be stored on the floor, stock containers should not be stored on the floor, so they need to be removed. But here's just an organization in clutter. Loose tablets on the floor. Is the pharmacy floor being cleaned? You would think if it was being cleaned regularly, these would be cleaned up. Here's two more examples of debris, tablets, and trash on the floors. Here's a recent photo of something growing out of the faucet. I'm not sure what it is, but the inspector observed that. I believe there was also stuff in the actual sink drain hole 2 growing there, if I remember right. But that's here's the reconstituted pictures. Again, where the tip, but you also need to be aware of that splatter all around the reconstitute. You can see in these pictures the sealing part of the reconstitute has a lot of residue on there. Another observation is when we're going through prescription files, looking at actual prescriptions, we come across what looks to be like a possible dispensing error. We're comparing what was prescribed to what the label or the computer shows as what was dispensed, either the drug, the strength, or the directions. And if we find that, we issue a quality assurance report that asks the pharmacist in charge to look into it more and respond back. This is an example of how many we did in fiscal year that just ended in July. You can see how many that were issued, well over 300 there. The most common reason is for incorrect directions. Sometimes it's just totally wrong directions of take 1 tablet twice a day versus what was prescribed said once a day. But probably the most common, definitely the most common direction issue is PRN, where PRN is being left off a label or it's being put on when it wasn't ordered PRN. Another thing we're seeing more of is different, where it's just when a SIG code does not switch over directly and no one catches that. So due to a typo or something that was supposed to say at bedtime, they typed it in with, instead of QHS, and which would win a quick code, they type in typo of PHS, and that's what ends up on the prescription label is take 1 tablet PHS, and no one catches that when it is going through the dispensing verification process. So we're seeing more of that. I don't know if I have a name. It usually has to do with quick codes not being entered correctly and then converted onto the label properly. But occasionally we do find the wrong drug has been issued or the wrong strength of a drug has been issued to a patient. Some issues related to compounding. We talked about this on previous webinars, but our regulation requires that any container that goes to the patient of a compounded preparation needs to have the unabbreviated names of all the active ingredients on that patient container somewhere. It does not have to be actually on the prescription label. It can be on an auxiliary label. I know there's software systems now that can custom print auxiliary labels that some people use for the compounds, but it can be as simple as handwriting it yourself on a label. But it needs to be unabbreviated. You can't be abbreviating the drug names when you do that. Issues with the compound log. Inspectors find compound logs when they review it that it appears that an expired ingredient was used in the preparation because that's what the compound log shows. This goes back to, a pharmacist checked that log. If not the one who filled it out, they're the ones who checked it. I'm not catching that. A lot of times it goes back to software systems that pre-populate the compound logs based on previous compounds of that product preparation that were made. It pre-populates, and the technician or pharmacist doesn't go in and update that to what's actually being used. There are times where we actually find there is expired ingredients being used in a preparation, which goes back. Another issue is why was that expired compound ingredient in your active inventory to begin with? So again, when you're checking for outdates, make sure your compounding section is checked for outdates when you do your inventory. And another issue is we find compound logs showing that a beyond use date was assigned to the preparation, but it exceeds one of the ingredients expiration dates. Again, it can be a pre-population issue, and other times we find it is actually they did assign it one greater than was actually used. So again, both of these bullets come back to is the pharmacist doing a proper verification of that compound log when they're reviewing it. and not just signing off on it. They should be reviewing it to make sure the compound was made properly with the right ingredients when they do that. As more and more pharmacy gets drug take-back receptacles, we're seeing issues with the records related to that. There's a requirement by both the board and the DEA that you take an annual inventory of your liners. A lot of times that's not done. My recommendation is just do it as part of your annual controlled substance inventory. That way you don't have to have 2 dates in mind. So that the other is the liner record itself. Both DEA and the board require detailed documentation of installation, removal, sealing, and destruction when those liners are being manipulated in and out of the receptacle. The example here is a MedSafe, is that the board's RX Care program uses MedSafe. That's who the pharmacies that are participating in that program get a receptacle from them. Each one of their liners comes with this record that all they need to do is fill out the different parts of it for that. So if the company you use don't do that, you can easily create your own standard format, so you're always recording the required information. And then you need to be able to produce this on inspection. We will always ask to see your liner records. So while we're talking take back, just a plug for the board's RX Cares for Missouri program. We still are providing free drug take back receptacles, including the actual box itself. We do provide 12, you get 12 liners with that. So those liners already have the cost for destruction built into that. All you have to do is send back the liner once it's full, and destruction cost has already been paid for by the board. Just a reminder, you do have to still comply with all board, BNDD, and DEA requirements related to the take back. The board's program is also available to law enforcement agencies. We have, I think, 3 or 4 maybe that now have boxes from us, but if you know a law enforcement agency that would want one, they can apply for one and get one. There's an application and more information on the board's website. Another observation is dealing flavoring bottles, and I will tell you this is the #1 reason we issue compliance notice at pharmacies is cracked or open flavoring bottles. So examples, these lids, I don't know what you call them, they're built so you can stick the syringe right in to draw out, are notoriously known for cracking, and here's an example of just overuse. The lids crack, or just pharmacies not capping them and leaving them uncapped. So again, this when you check a pharmacist in charge or the pharmacist working, you walk by your flavoring station probably multiple times a day. Do you ever look to make sure the status of it? But again, this is the #1 reason we issue compliance for the last couple of years, I would say. Other observations, counseling, always a failure to offer counseling on all new and refill prescriptions when the patients pick them up, or provide a written offer if it's a delivery or mail out. Also find examples of technicians providing counseling. Only a pharmacist or a supervised intern can counsel, but we inspectors over here, technicians providing counseling to patients, answering questions about the drug, the prescription, even providing recommendation on over-the-counter products. And we've also, now that technicians are allowed to do immunizations, we've heard technicians counseling patients on such things as like how to treat an adverse reaction if you have one to administration. So again, this is usually an education issue for your staff, just to make sure they're offering that counsel and they're not providing any. The annual controlled substance inventory, usually there's issues with that. It's not taken on time, it's late. See times where the different schedules are taken on different days. That's not allowed. They need to be taken all on the same day. Missing open or close or a date and time if you're a 24-hour store. When was that inventory taken on the day needs to be noted. In Missouri, because over-the-counter pseudoephedrine is Schedule 5 in Missouri, you must inventory that on your annual inventory date. And then occasionally we find the C2s, for whatever reason, you got a new printout or something and it didn't segregate the C2s, but C2 records are for the inventory do need to be kept on a different sheet of paper separate from the 3 through 5. As more and more pharmacies are offering multi-med packs, we're finding issues with that, usually about labeling or records. Labeling the rule specific, it's not just your standard pharmacy label that goes on a med pack. There needs to be more on that med pack labeling on the pack itself. And then records, we do require records that's specific to each pack that you generate. Sometimes the issue is the data, you're just unable to get the data that we want to see out of if you're using a robotic system, the software having trouble getting that out. So if you do have automation that does med packs, you do want to make sure you ask your vendor if you're not aware of how do you pull out the med pack record that the board's going to ask for, because the data's in there. It's just inspectors see licensees struggle with how to get it out of the system. And then changing prescriptions without documented prescriber authorization is something the inspectors come across regularly. The board has, for the last couple of years, tried to get a statute, proposed statute change to allow pharmacists some authority to make changes. We've been unsuccessful in getting that approved to be filed, but you can always it would be a big benefit, I think, to all practicing pharmacists to be able to make some changes without having to call the prescriber or get authorization from them. You can make recommendations to your organizations, and maybe they can take the lead in trying to get a statute passed that would help us. Immunizations, related to that, some of the issues we see is unable to find or produce the current protocol. And then sometimes the pharmacist has not signed the current protocol, so they don't technically have a current one. And then for COVID-19, again, we still find vaccine being taken out of the refrigerator or freezer or punctured with no date or time on when those things occurred. You need to make sure those things are properly documented on the product so there's no question. So here's an example of a bin that had some syringes in it and a vial. No idea when that was taken out or punctured. As part of our inspection program, we do take samples of compounded preparations, and unless you read our annual report, you probably never know what our results are. And last year, fiscal year, we collected 46 samples, 13% failed potency, none failed sterility or endotoxin testing. And the 13% fail rate is if you can see over the last 5 years there, so that's good, it's going down. But it probably averages in the 20 to 25 range, and so we're below that last year, so that's good. But we do collect those during inspections. If it does fail, we do get back in touch with the pharmacy and ask them to fill out a quality assurance form and investigate that. Just briefly on some investigation trends. We have been seeing an increase, and these are investigations that are assigned to inspectors. So most of these are coming in from the public. The vast majority come from the public, other agencies. Some are initiated by board staff inspectors themselves, but we have seen a major increase. Last fiscal year, it went up 36% from the previous year, so that's a big jump. And so the first quarter of this year, so from July to September this year, we've seen a 13% increase. So things are going up. Inspectors are out more doing investigation work instead of inspection work. So that's one trend. Here's kind of a breakdown. It's unofficial. This is just kind of how when they come in, I kind of track and put put a topic in there. And tech termination has always been the #1 category of what a complaint's about. But recently, over the last year or two, prescription delay and refusal to fill have been creeping up. This is patients complaining that they can't get a prescription filled. They're unable to reach the pharmacy, stuff like that. Refusal to fill usually most time deals with opioid prescriptions. A patient's upset that a pharmacist won't fill their opioid prescription due to various reasons. And then the COVID one, well, that's new in the last couple of years, but we do get complaints related to different issues related to COVID. Usually it's COVID vaccinations is the cause. So that's just give you an idea of what's out there. So now I'm going to just on some slides answer some questions that we get commonly. Since it's renewal time, we get lots of questions this time of year over CE. One is, do I have to have 15 hours for each of the 2 separate years of the renewal period? And the answer is no, you just need to have 30 hours during that renewal period. You don't have to break it down and have 15 during each of the 2 years. And then what counts for MTS CE? I think someone just sent a question in right before the webinar about this. So for those that aren't aware, if you have an MTS certificate on your license, when you renew, you have to have 6 hours of CE that is related to drug therapy or disease state management. And we will accept any ACPE code 01, and that is disease state management drug therapy. And those codes have the 01 in it. And I have an example what an ACPE code looks like. And it's that second to the last section there has, I forget how high the numbers go. I don't know if they're up to 10 yet or not, but there's different codes for different types of the CEs that's out there. We will take any 01 to meet that. We will also take other codes if they're related to drug therapy or disease state management. There is a code for pain management and opioids, or there may be one for each, I can't remember, but not all opioid CE may be drug therapy or disease state management related. So we'd have to go down to is what was actually discussed on that. So it's not limited just to code 01, but other codes would need to be related to drug therapy or disease state management. Another question is the audit. Yes, the board will be auditing. We don't do a random audit anymore because we audit everybody. Most people, it's seamless because we have access to the CPE monitor, and anyone who has 30 hours there, you've already passed the audit. For those that don't, we then go and look at what CE we've issued through like our webinars. And then if I add those together, you have 30, you already made it through the audit. There is some CE that's board approved that that would not be included, and you might be audited if you're using some of that. And the examples would be if you have an organization that has the board approve their CE and they put on the program and they issue the certificates. We don't know who they issued certificates to, so you would always want to make sure you keep your certificates for any board approved CE that's being issued by, say, a hospital or someone's ground rounds or someone like that who's giving CE for those. The other is if you do the practice guide exam and the self-assessment, those may not be included in what we're tracking. So you always want to keep your CE certificates for those. If you don't have 30 hours in all our preliminary checking, you will get a letter asking you to produce your actual certificates. Some immunization questions. Can a pharmacist give the influenza vaccine to ages 3 to 6 using a protocol? The answer is no. In Missouri, a protocol for flu can only go down to age 7. However, the Federal PrEP Act does give pharmacists their own authority to order and administer influenza for ages 3 and above. So you don't need a protocol to do this. You already have the authority to do it. And any prescription that is generated from that, the pharmacist would be the prescriber on that prescription if you have to create a prescription for that. You need to be following the PrEP Act requirements for that, but a protocol, there is no allowance to use a protocol for that age group of 3 to 6. What vaccine does the PrEP Act cover for pharmacists? Well, the COVID-19 from ages 3 and above, influenza ages 3 and above, and childhood vaccines ages 3 to 18. Those are all part of the COVID PrEP Act. And then earlier this month, the smallpox, it was called the Smallpox and Other Orthopox Virus PrEP Act, was revised. They changed the name of it and put monkeypox in the name of it now. But it now allows pharmacists to vaccinate for monkeypox. I don't believe there is an age limit in there. I think it would be relying on the manufacturer or CDC recommendations on that. I don't know, I don't recall it spelling out a specific age group like the COVID PrEP Act does for those three. But for these things here, the pharmacist has the ability to order and administer these on their own. Does a technician need to be certified to give the COVID-19 vaccine? The answer is no, because the Federal PrEP Act preempts state requirements on training and eligibility of that technician to do it. The PrEP Act does not require a technician to be certified. The board's rules do, so the vaccines that are covered under the board's rule would apply, but it doesn't apply to influenza and childhood vaccine because the PrEP Act is preempting our requirements. But for shingles, meningitis, stuff like that, the other vaccines, tetanus, stuff like that are allowed to be given by a pharmacist. The technician would have to be certified by board rule. So it all depends. It really comes down to what vaccine you're giving on when it comes to, does a tech need to be certified? And then the last one, we've been getting questions on competency assessments. If you've been following the board's rulemaking for the last couple of years, most of these new rules that are giving people more authority to do things, your staff to do more things, has been including this phrase that they have to have initial and annual competency assessments. So this is the list I created of the things that require these competency assessments. Sterile compounding is down at the bottom. It's always required that. But these other ones are all fairly new rules in the last 2 years that are allowing technicians and interns to do more. And the board believes, if we're going to allow them to do more, we need to make sure that on an ongoing basis that they understand and can prove that they understand what they're doing. So that's just a summary. They are the ones you really need to go in and look at each rule specifically, like the class Q. It's depending on what the technician is doing at the pharmacy, whether they have to have one or not, I believe. So you just need to look at the rule more closely for the requirements. So we're now going to switch to the question and answer session, and we're going to start with some of the ones that got submitted in advance to us. So Dan and Barb are going to help me answer some of these. So I'm going to read them off, and one of them will answer them for us. So we'll get started. So let's see. These next ones kind of go with the last slide, talking about assessments. Has the board created a standard template that a pharmacy can use to do these assessments?
This is Barb, and hello everyone. The answer to that question is no. The board has not created a template at this time, but permit holders, pharmacists in charge, should develop an assessment that covers their specific pharmacy.
Okay. Is the assessments only for technicians or both technicians and pharmacists?
This depends on the rule. For sterile compounding, it would apply to pharmacists, technicians, and interns. For administrations and immunizations, it would apply to technicians. For the others listed on the slide that was last shown, it applies to interns and technicians.
Yeah, so this one, again, you got to go back and read the rule. Each one's, there's so many of them now, you got to read them to find out what's required. Someone's asked, what does the assessment need to cover? Is there a checklist, or what's required to be covered on that?
Well, the board did not develop a specific list, but it's leaving that up to the permit holder and the pharmacist in charge to develop one that fits, and it will include the activities the technician or intern is performing.
Okay. Let's see. Here's a question about one of the new rules that took in effect in August, requiring gloves being worn when handling loose tablets and capsules. They want to know, does that mean I have to wear gloves when I'm touching the spatula or a manufacturer's stock bottle?
Hi, this is Dan, and to answer that question, the answer is no. So if you're counting tablets out on a counting tray and using a spatula, you don't need to wear gloves. You also don't, but you should. The time that you should wear gloves is like if you're filling a bubble card or multi-med packs or something like that. So that's the answer for that.
Let's see. Another question related to the newer rule that allows licenses to be in a central location instead of on the wall. They want to know, does this mean they can be in a file cabinet as long as the pictures are there?
Yes, you can keep those in a file cabinet. There's no problem with that at all. Just got to be able to readily retrieve them. And then you also want to make sure that there's a photo attached to that license.
Yeah, you just can't have a stack of licenses and a stack of photos. The licenses and the photos need to be attached to each other. Okay. Here we go about tech certification. What activities require a technician to be certified?
In general, Missouri does not require a technician to be certified. However, technicians performing various activities are required to be certified. Some examples would be technology-assisted verification, Class R remote dispensing sites, a Class Q charitable pharmacy, immunizing by protocol, or administering by prescription order.
Okay. Change topics here. This is about schools. Can a pharmacy sell albuterol inhalers and EpiPens to a school? If so, how do they document this?
Well, the answer to that question is yes. State law allows a physician to write a prescription for asthma rescue drugs and epinephrine autoinjectors in the name of the school district, in the name of the school district, but the name of the school nurse must be on the prescription as well. The pharmacy would then fill it as a regular prescription.
And then a follow-up to that, can a pharmacy sell naloxone to a school?
The answer to that is also yes, but a prescription issued in the name of the school district is not allowed. There are a couple of options for this. A pharmacist could use the DHSS standing order and dispense it to the school nurse. And there also is a different state law that would allow it to be distributed directly to the school if the school is acting under a standing order with a prescriber.
And that one's a little more convoluted. The use of the standing order and going it to the school nurse is probably the easiest method to do that, but there is an allowance that would allow you to distribute it also. Who would be listed as the prescriber when you're doing immunizations?
So this depends on where the pharmacist's authority to immunize comes from. As you know, Tom talked earlier about you can immunize based off of the HHS PrEP Act, childhood immunizations and the list that goes along with that. If it's under the PrEP Act, then it's the ordering pharmacist that would be listed as the prescriber. You can also immunize from a protocol position. So for the state COVID standing order, it would be Dr. Turbolisi then at that point. And then of course, if somebody brings in a prescription and it's, you know, you're doing about under a medical prescription order, then it's the name of that physician that's on the prescription.
Okay. This one has to do with e-prescribing. Can pharmacies still accept paper fact controlled substance prescriptions?
Yes, they can. So there's a state law that requires e-prescribing for controlled substances, and it within it. So there's 11 exceptions to it, but a pharmacist who receives a written, oral, or fax prescription is not required to verify that the prescription properly falls under one of those 11 exceptions from their requirement to electronically prescribe. So that's kind of unusual. This is one of the first laws that they basically said the pharmacist doesn't have to be the policeman in this. So, you know, the pharmacist, basically, that's incumbent upon the prescriber to determine whether or not they fall within one of the 11 exceptions.
Okay, let's see. We got some remaining to prep back here. So does Missouri allow pharmacists to prescribe Paxlovid?
The pharmacist must comply with the PrEP Act and the EUA requirements on this matter.
And then they can do it. The board itself hasn't granted any authority, but the PrEP Act does. So that you, as Barb said, you have to follow the PrEP Act on that. Has the board issued any guidance on monkeypox vaccines and treatments?
The board, as we speak today, the board has not issued any guidance at this time. Pharmacists, interns, technicians, they must follow the PrEP Act requirements when administering the vaccine or the therapeutics. This is not the COVID-19 PrEP Act, but the smallpox, monkeypox, and other orthopox viruses PrEP Act that Tom had mentioned on a previous slide. Was revised this month to cover pharmacists, interns, and technicians.
A common question, what is the status of Missouri's PDMP program?
It's still in a development stage. It's expected to be active sometime in 2023. The Board of Pharmacy, I get this question a lot too. The Board of Pharmacy does not run the PDMP in Missouri. That's done under the Office of Administration, and they have hired an executive director. So the ball is rolling, and it's Dean Linneman. If you have any questions on the Missouri PDMP, those really should be directed to the Office of Administration and Dean Linneman.
Someone's asking for a more detailed, specific update on what's going on with USP 797 and 800, and what's the board's plans on these two?
Let me preface this. So anything that we answer today, we can only answer on behalf of the Missouri Board of Pharmacy. So we can't respond, you know, if it's another agency's jurisdiction, and I know some people fall in that, but Missouri has not adopted USP 797. We have our own sterile compounding regulation. Once the 797 does become final, the board will look at that and determine, do they want to make any rules changes, you know, from that, or do they want to adopt it in whole, or, you know, that's basically down the road. The board would look at that once that becomes active. Concerning USP 800, the board has not addressed if or how they will adopt or enforce that. The board would need to promulgate a rule before they would enforce it, and at this time, no such rule has been promulgated.
Okay, switching gears to 3PLs, does Missouri license third-party logistic providers?
The answer to that is yes. Missouri does require all 3PLs in and out of state to obtain a Missouri 3PL license.
Let's see. Can a pharmacist give polio shots by protocol?
No, it is. And the reason is it's not one of the vaccines allowed to be given by the protocol. However, it can be given by prescription order by obtaining a patient-specific prescription/order.
Okay, this is a hospital-related question. They're asking about the allowance to send home, they call bulk items that are used during a hospital stay on discharge without having to go through the creating a prescription and dispensing it as a prescription. What's the standard on that? Is that allowed?
So the Department of Health and Senior Services have a regulation that allows medications in multi-dose containers that were administered to or used for the patient during the patient's hospital stay. They may be sent with a patient at discharge. And if you want that specific regulation, it's 19 CSR 30-20.100. And I just have to refer you to that regulation for their specific requirements.
Okay, and our executive director, Kimberly Grinston, has joined us now, and we have a question related to working conditions and pharmacies having metrics related to testing, vaccines, and stuff like that. So, Kim?
Hi, and good afternoon, everyone. Thank you for joining us for the webinar. So I am going to respond to the question. We at the board office continue to get questions and comments, of course, about pharmacy working conditions in the state of Missouri. And as you all know, this is an issue and a discussion nationwide. The board recently promulgated several rules, 2.010 and 2.090, that included some additional language to address some of what we are seeing related to pharmacy working conditions. I would encourage anyone who has questions about that to view the webinar that we did on new regulatory changes in August, and there will be additional information on there. But let me just provide just a general answer on what the board is doing related to pharmacy working conditions. In addition to reviewing the board's rules, and again, we just made some regulatory changes that will give both the board and licensees more legal authority and direction in some of those arenas. We are also looking at this on a complaint basis. So as complaints come in, and we've gotten complaints from the public, from licensees, the board is reviewing pharmacy working conditions in relation to those complaints. Board inspectors are also independently reviewing pharmacy working conditions and have authorization to initiate an investigation if appropriate, if they observe or suspect that there are pharmacy working conditions that impact patient safety. I have to be clear here, the board doesn't regulate employee practices, but we do. And we are responsible for protecting patients. So to the extent that there is an issue that may threaten patient safety, the board will be investigating those. In addition to that, we've gotten questions about the new rule 2.010 or revised rule that provides or prevents permit holders from adopting any metric or goal that inhibits or threatens patient safety. I think that is the exact language. The board will be looking at that statewide for permit holders over the next year or so. And we've actually already begun that process. And again, this is complaint driven. So if there is a specific complaint related to metrics and goals, if we have sufficient information, the board is investigating that as well. Once again, our investigators and board inspectors who are pharmacists will also be looking at metrics, goals when they are on inspection and also on investigation, especially for things that relate, again, directly to patient safety. I understand that not everyone can file a complaint, and sometimes that is not the best option for some of you. I understand that there are fears of retaliation and or adverse action if you file a complaint. The board may, in very limited circumstances, look at an anonymous complaint, provided we have sufficient information that shows that there's an issue under the board's jurisdiction. So to the extent that you believe that there is a metric or goal in place that threatens patient safety at your work area, complaint information is on the board's website. If we have information, number one, about the metric or goal specifically that you are referencing, also the pharmacy that you're referencing, when you have a pharmacy that may have multiple locations in the state, simply referencing them by name or the pharmacy on ABC Street really doesn't give us enough to pursue an investigation. However, if you give us sufficient information to take a look at some of those metrics or goals issues, we will do that either on a complaint basis or on an investigation basis. I want to echo that it needs to be more than just we're very busy. We need to know specifically, again, how that goal what goal you're referencing. Is it immunizations? Is it prescriptions per day, prescriptions per hour, and how it is specifically impacting patient safety. So this is an issue, again, that all boards of pharmacy are currently considering. The board takes this very seriously, and we have begun to revise our investigation process to look at some of these issues. You all are our best resource, so we encourage you to contact the board if you have something you believe in fact does threaten patient safety. So that's my general answer, and I'll stick around just in case there's something else for me.
Thank you, Kim. If you have questions for us, you can submit them on your toolbar, type them in there and hit send. We'll take a few, see what has come in during the program. Do drugs expire on the first of the month on the label? I'm not exactly sure what's being, if you're asking about a return to stock, if that's the label you're talking about, it expires on the day, 12 months from the date it was dispensed. So I'm not sure if you're talking about a manufacturer's expiration date that says like 10, the expiration date says 10/20/22, then a manufacturer's product would expire at the end of the month for that one. So it would expire on October 31st. So I'm not sure if I answered that one correctly, or if that's what you were asking.
So another question we got, is it okay for the technicians to make the offer for the patients to counsel? And the answer to that is yes. It doesn't have to be a pharmacist that makes that offer to counsel. It's just an offer to counsel does have to be made.
Someone's asking about therapeutic interchange for long-term care facilities. Is the board considering it? The board is actually was one of their proposed legislation things, I believe 2 years ago, that we did not get approval for. So yeah, the board is considering it, but it will require legislation, and that has the board does not have the authority just to go out and sponsor a bill. Again, as I mentioned earlier, talk to your associations about things like that, and maybe they can assist with getting the ball rolling on that.
Another question we got is, we had a slide earlier about technician and pharmacist termination complaints, and that being a certain percent of the complaints. And the person asked, are they trying to have those employees fired, or is that no, they're not. That's just a complaint that comes in that they're required. You're required to report technician terminations, and that's and that's why that complaint gets generated.
They're called complaints, but actually those are statute mandated reports the employer has to submit to us when a technician or pharmacist are terminated for a reason the board could take action. So they're required to report those things to us. Someone wants to know, is there a CE requirement for the MTS renewal if you're a PharmD? The answer is yes. What you're thinking of, a PharmD does not have to have a specific, go through a program in order to get the MTS certificate, but to renew it, they do have to do 6 hours of CE. So yes, the answer is that. Someone else wanted to know a CE question about today's webinar, can I use it for next renewal? The answer is sorry, no. It would only be good for this one because it's the next renewal doesn't start until November 1st. So sorry about that. Someone wants to know, can a technician administer a vaccine that is under the PrEP Act if the pharmacist on duty is not certified to administer the vaccine? The PrEP, you'd have to go to the PrEP Act. The board does have a requirement for under our jurisdiction that pharmacist has to be certified just like to supervise that technician. I do not believe the PrEP Act requires that, but you would need to go look at the PrEP Act because it is preempting our laws on that.
Got another question. It said, are nurses allowed to dock an antibiotic to diluent from Pyxis for immediate use? This isn't considered compounding, right? That's actually a question we defer to DHSS,
Yeah, I'm not
since
sure.
it's probably occurring within a hospital.
Yeah, depending on what facility, if it's at a long-term care facility, that too would be under Department of Health. So we wouldn't be the ones to answer that. Someone's asking how to report the compounding data to the board. We sent out a news, an email alert, I think it was last week or the week before, telling that the board has extended that. You will not be required to report your compounding data in January of 2023. They're postponing it until January 2024. Due to the MOU, federal MOU has not been totally finalized and on that. So there was an email alert, I think it was last week, on the topic. So you might look at, you can see past alerts on our board's website. We now have all those on there, so you can go back and see if you missed that on that. Okay, well, we are almost out of time. One more, since it's a hot topic, CE. For CE records, is it sufficient to provide an activity tracker such as Medscape instead of providing each separate certificate? If you're audited, we will accept the CPE monitor if you do a printout from them, or you're going to have your individual certificates. So the best would be to go to the CPE monitor if you need a printout and just want to do a printout. Okay, so we're going to run out of time here. So let's see. If your question didn't get answered or you have more questions, some places you can go to get answers is the practice guide. We have a 2020 revision expected out by the end of the year. It's currently being in the draft right now. We hope to have it done by the end of the year. There's a lot of things changing with all the new rules that will be updated in that. Just one tip for people using the practice guide, if you do Control F find and just search for the topic, because that practice guide is getting longer and longer and longer. We do have a index at the beginning that takes you to sections, but if you're looking for a specific item, you might try typing in the word and seeing that you might find it easier that way. You can always email your inspector. If you have a question, you can email the board office at the general email address. There's also a way to submit questions to the inspector or the board's office on our website. And then for controlled substance questions, BNDD would be your source for those, and their email is bndd@health.mo.gov. As I said earlier, we do record all our webinars. It can take up to 15 days sometimes for us to get them posted. We've had 6 other webinars so far this year. I listed them. You can always go back and watch any of those at any time. You do not get CE for watching them after the fact, though. Moving on to CE, if you want to get credit for today, you must answer the post survey that will pop up on your screen. Do not close your browser. When I announce that I'm going to close the webinar, a little screen that will come up that say that. You hit close on that, and again, do not close your internet browser, and then a survey will open. You answer those 5 questions and click submit. For some reason, if you do not get the questions online, you can email us at compliance@pr.mo.gov, but you must, if you do that, you must have your answers back to us within 24 hours. You can we email you the questions, you email us back your answers, but we have to have them back in 24 hours for CE. We do email certificates now. We do not physically mail them, and that can take up to 30 days. However, recently we've been pretty prompt on that, going out, I think, within the next week, but I can't speak when they'll go out, but usually within 30 days. And again, save your certificates because we do not report to the CPE monitor. Again, I want to thank Barb and Dan for joining me today on our webinar. And I want to thank all of you for attending today. So I am now going to close the webinar.